Hi, I'm Dr. Paul Vastola. I'm a board-certified otolaryngologist at Maimonides Medical Center. I'm fellowship trained in Pediatric Otolaryngology, and I currently serve as the director of the Division of Pediatric Otolaryngology. I was trained in Boston, Massachusetts at Boston University Medical School. I graduated in 1988. And during that time, I met a gentleman named Charles Vaughn, who was the chief of otolaryngology at the VA hospital. He inspired me greatly to go into the field that I'm currently in, which is otolaryngology, also known as ENT. So as I got through medical school, it became apparent that I wanted to be in a surgical subspecialty. And after considering all my options, I decided to apply for otolaryngology and did a two-year residency at New York Hospital, Cornell Medical in Manhattan, and finished up with 3 years of otolaryngology training at Manhattan Eye and Ear. During that time, I fell in love with kids and really enjoyed taking care of problems in the pediatric population. And some of my mentors at Cornell were also pediatric otolaryngologists who I really greatly respected. They were friends of mine, and I decided to pursue that and did a fellowship at Baylor in Houston, Texas. I have a great interest in airway problems in children. A lot of what I do is bread and butter, such as tonsils and adenoids, but the really challenging and rewarding things for me include getting kids who are tracheostomy-dependent, that is, they have a breathing tube in their neck, getting that out so they can resume a normal life. That is probably one of the most interesting and challenging things that I do in my daily work. My philosophy is overwhelmingly less is more. Lately, there's been a great shift in thinking away from the use of antibiotics for a lot of common conditions in children. Most things that pediatricians see in their offices are self-limited. A lot of things are viral, and for that reason, people have gotten away from the idea of using a lot of antibiotics to treat common issues. Having said that, we see a lot of problems which do require antibiotics and even more powerful medications, oftentimes surgery. But I find that by starting with fundamental thinking and understanding the anatomy and physiology of the upper aerodigestive tract, that is the ear, nose, and throat, you can get great results with very oftentimes simple things, which is quite wonderful. One of the big trends in our field is using balloons to dilate sinuses and airways. In the past, we'd use surgery to actually remove bone or split open the airway and put grafts comprised of rib cartilage in the airway. We would also use lasers and powered instrumentation. However, now, believe it or not, and this harks back to the less is more philosophy, we can use balloons to dilate open sinus tracts, allow greater drainage of the sinuses into the nose. We can dilate the airway and reestablish normal breathing patterns by using a relatively simple concept, and that is balloon dilation. That's one major thing that in the last 2 years has really taken root. Another thing is a basic understanding of immunology and realizing that a lot of what occurs in the pediatric upper aerodigestive tract is based in immunologic phenomenon. And understanding those phenomenon and tapering medications to that has allowed us to extend our reach greater. And we have had great success in treating a lot of conditions, including asthma, reflux, and sinusitis, with a greater understanding of the molecular problems that occur within these areas. I would have to say that relatively new modalities of cutting tissue have changed the way we do surgery. It used to be in the old days you'd use a knife to cut tissue, but we've now come of age where we're using instruments which impart much less damage to the surrounding tissues and therefore have much faster recovery times. There's also a concept of powered instrumentation, using little drills and such that are able to go into these areas and open up drainage pathways and that sort of thing. And finally, the actual visualization, the optics, and the ability to record what you're doing have also greatly enhanced what we do on a daily basis, because we can share things with our colleagues and review what we've done in the past in a very easily accessible manner. I've been in practice for almost 20 years. I see thousands and thousands of kids every year. And what I'm mostly interested in doing is improving their quality of life. Most of what has been done in the past 4 or 5 years, research-wise, uses quality of life as an endpoint indicator to determine whether or not what you're doing is successful or not. Having said that, I think that, again, to reiterate, my overriding philosophy is less is more. I try and do the most efficacious, that is the most effective thing, with the least amount of pharmaceuticals or side effects or surgery. I see probably 5,000 or 6,000 kids a year, and I maybe operate on 1/10 of those children. The rest of them we get better with simple medications or changing philosophies or environments in the household. People ask me, what is a pediatric otolaryngologist? And the best definition that I can come up with is someone who takes care of unusual problems in normal kids and common problems in unusual kids. I would have to say that one of the most gratifying things that I've done in my career over the last 15 years is become involved in the cleft lip and palate service. Here at Maimonides Medical Center, we have a multidisciplinary group that meets every month, and we take care of children with significant functional and cosmetic abnormalities. These abnormalities often are congenital, and they can be repaired surgically. And I have been privileged to travel to South America to help in these medical missions, repairing children's palates and providing ENT care in southern Colombia.